Good afternoon. I'm Dr. Sumedha Sahni, Head of Medical Affairs for BD for EMA. On behalf of Integrated Diagnostic Solutions, I welcome you all to today's event. I will be your moderator for the day.
Our topic for today's webinar is COVID-19, Experience Sharing from South Korea and the United Kingdom. Let me introduce to you the agenda for today's webinar. Our webinar will last about 90 minutes, and our first speaker of the day will be Dr. Ki-Ho Hong, who will speak on COVID-19 laboratory testing in Korea. We will have a short question and answer session, and that will be followed by our second speaker presenting, who is Professor Kevin D. Rooney, who will speak on COVID-19 in the ICU, our experience in Scotland. Professor Rooney's session will be followed by a question and answer session, and then we will close the webinar. Dr. Ki-Ho Hong is the Director of Laboratory Medicine at Seoul Medical Center, Republic of Korea, a dedicated lab professional. Dr. Hong has conducted extensive research in the field of infectious diseases and was very much on the scene during the MERS-CoV outbreak as well. Dr. Hong is the Infection Control Director of the Korean Society for Clinical Microbiology. With the commencement of the COVID-19 epidemic that rolled into a pandemic worldwide, Dr. Hong has been an active member of the COVID-19 task force and continues to be deeply involved in the control of the situation in the Republic of Korea. Let us hear from Dr. Hong now.
Thank you for nice introduction. And I'm Dr. Ki Hong from Seoul Medical Center, and I'm a member of the COVID-19 task force of the Korean Society for Laboratory Medicine. And today, I'm going to talk about COVID-19 laboratory testing in Korea. So when you need in pandemics such as COVID-19, what you need is testing. It is the first step of the pandemic response, and you need accurate, massive, and rapid testing. And you should choose which test you perform. So this is the role of laboratory diagnosis in COVID-19, and when you perform diagnosis, and you should choose RT-PCR, but when you perform epidemiological surveillance or before the diagnosis or after the outbreak, you should perform antibodies testing. So this slide shows three methods of laboratory diagnosis of COVID-19. Viral cell isolation is not practical, and it can be only performed in biosafety level 3 laboratory. And the most widely used method is molecular assay. It is for the diagnosis of acute infection, and it is very sensitive and specific. And however, it is very expensive, and it needs huge infrastructure. And most widely used method is real-time PCR. On the contrary, immunoassay is very cheap, but less sensitive and less specific. Antibody can be used for detection of past infection. I'm sorry for the misspelling, and for cell surveillance. And antigen assay, it can be only used in limited resource setting where the molecular assay cannot be performed. So this table shows basically same contents as before slide, and molecular diagnosis using several target genes such as the E gene, RDRP gene, and spike gene. And sensitivity and specificity is very high, and it can be used for acute diagnosis, and WHO and CDC recommends it as a diagnostic method. And immunoassay includes antigen assay and antibody assay, and particularly antibody assay, it can be detected after 7 or 14 days after symptom onset, and it is used in part of China. So what we need for performing molecular tests in outbreak situation, before outbreak, you need facilities and devices such as isolated laboratory and biosafety cabinet and autoclave, and a device, it means thermocyclers, and most importantly, medical experts performing and interpreting tests are needed. And after the outbreak, you need test kits, and many test kits, and reliable and very good quality, and you need other supplies such as swab and transport media and box and personal protective equipment, and there should be cooperation and communication among government and laboratory and experts and IVD companies. So this is an example of supplies presented by WHO, and it includes triple packaging boxes and swab viral transport medium and RNA extraction kit, RT-PCR reaction kit, and thermocyclers, etc. So you need many things to perform molecular tests efficiently. In Korea, thermocycler is widely distributed after 2009 influenza pandemic, and there are large expansion of molecular diagnostics markets, and there are many molecular diagnostic kits companies, and we have medical specialists for laboratory medicine and the doctor such as me, and we perform molecular tests in medical view with the centralization and professionalism. And Korean Society for Laboratory Medicine, who performing laboratory inspection and external quality control program, which are very important in good quality of molecular tests. So in late January, we activated the emergency authorization kit processing, and EUA system was established in Korea after 2015 MERS experience, and Korean Centers for Disease Control and Prevention, KCDC, and KSRM have been evaluating PCR test kits together, and KCDC provided clinical specimens, and we evaluated the PCR kits together, and Korean Ministry of Food and Drug Safety approved the kits on the basis of evaluation results. And it was a very simple evaluation because we have only a few patients and only a few clinical specimens in late January. So to overcome the simple evaluation and the expected deficiencies, we have some limitations, and we only approved the qualified laboratories to perform COVID-19 molecular tests, and the laboratories are accredited for molecular tests by Korean Laboratory Medicine Foundation, and we perform education programs for all the laboratories are performing COVID-19 testing, and we developed guidelines and Q&A for laboratories, and we perform external quality assurance programs, and every laboratories should have passed the EQA program before they start testing. And we finally collect and analyze the result, and every positive result in daily test result, and this for quality assurance and also for laboratory surveillance of COVID-19. It is our timeline, and we activated the EUA process at January 27, and we approved the first commercial PCR kit at February 4. This Cogen Biotech company, and we performed the first molecular test from February 7 in hospital laboratory, and we published laboratory guidelines and Q&A documents in February and March, and we performed a large-scale external quality assurance program using inactivated viruses at March 25, and currently there are 7 EUA PCR kits in Korea. These are guidelines and Q&A documents for Korean laboratory, and I wrote guideline, and it has English version has been published, and Q&A documents, English version of Q&A documents are in press, so you can see it in a few days. Okay, I got some questions from audience, and this is one of the first question, and he asked which specimens are best. So there are meta-analysis results and published in last month, and in this result, sputum is highest detection rate, and oropharyngeal swab and oropharyngeal swab. But you can the sputum is not is quite hard to get. The patients cannot express sputum well, so basically nasopharyngeal swab and oropharyngeal swabs are most widely used, and so it is recommended that both nasopharyngeal swab and oropharyngeal swab simultaneously, and if the patient can express sputum adequately, the sputum can be tested. And one another question is, can we use saliva instead of sputum or nasopharyngeal swab? Currently, there are several scientific reports about saliva assessment, and most results said that the sensitivity of saliva assessment compared to nasopharyngeal swab is about 80 to 9%, so it is less sensitive. But if you have very pure swabs for correcting nasopharyngeal specimen, you should use saliva instead of nasopharyngeal swab. But in Korea, saliva is not widely used. And you should choose which test kits you may use in your laboratory. And there are many test kits with poor quality. And about Korean products, I think you can trust test kits that received Korean EUA, but however, some Korean kits are exported without evaluation and Korean EUA. So when you use such test kits, you should check as many as information possible, including manufacturer's documents and EUA documents produced by country other than Korea, and most importantly, evaluation reports and reliable academic papers you should check, and do not trust preprint version of evaluation reports because they have many limitations. There are some laboratory developed test protocols, including Coleman's protocol and China CDC and USA CDC, and the below side of table, there are 7 commercial kits in Korea which got Korean EUA, from PowerCheck to Kerogen. There are some concerns about mutation can affect the sensitivity of test kits, and in last month, a report was published in Lancet Infectious Disease, and the report some mutations can affect China CDC's engine code primer, and so about 14% of the mutation cannot be detected by China CDC protocols. So we should check the mutation regularly. So one important lesson from our guideline document and Q&A document is that retesting is always important, particularly in values close to the cutoff values, which means the low viral copy number, and it can be false positive or false negative. So the laboratory director should interpret the result, and if necessary, retest should be performed using residual or new specimens. So we have performed 4 EQA programs in Korea, and first 3 EQA program was brief, and it was before the laboratory start testing, and we used plasmid DNA for the EQA program. However, the 4th EQA program is quite large scale, and 95 laboratories are included, and we used 10 samples consist of inactivated virus, and detailed results of the EQA programs are in progress of publishing. So from our EQA experiences, we recommend that every laboratory expert should continue monitoring and analyzing the performance of test kits, and how good assays performance you may use, there are still room for improvement, so we can keep performing quality control activities. And now I'm going to talk about rapid molecular assays such as the CEPED expert. And there are some rapid molecular assays that received the USA EUA, and CEPED expert, film array biofire, and advertising QRs and QSS such as SIM. And they are optimized for special cartridge and devices, so they can produce faster results than conventional real-time PCR, generally less than 60 minutes. And their accuracies are comparable to conventional PCR. However, they are very, very expensive. For example, QStat, the price of a single kit is €700, and there are some capacity problems because most of the rapid molecular assay can perform only a single test simultaneously, except CEPED expert. So if you want more tests simultaneously, you need more devices. So the rapid molecular assays are suitable for emergency departments or pre-operation screening tests. There are some evaluation reports of performance of rapid molecular assays. In general, advertising now have limited sensitivity, in particularly for samples with low virus copies, and GeneXpert seems to show generally good performance, and BioFire and QIAGEN may show good performance, but there are only few reports about them. So in present, GeneXpert seems to show most acceptable performance. Now I'm going to talk about antibody tests. Many agencies, including WHO, CDC, said that antibody tests are not for acute diagnosis, and we do not recommend antibody tests for acute diagnosis in Korea. This is a report from National COVID Testing Scientific Advisory Panel, United Kingdom, and the conclusion of this report is that most currently available commercial lateral flow immunoassays do not perform sufficiently well, so you cannot use it for individual patients. There are some meta-analysis of performance of antibody tests, and Karina reported that fold sensitivity is about 85% for total antibody and 82% for IgM antibodies, and specificity is generally good, and the heterogeneity of performance was high, and for low prevalence population, the positive predictive value cannot be high. So they conclude that use of serological tests for large scale, I'm sorry for misspelling, large scale prevalence surveys are only justified in hard hit regions. And Kanto also shows some meta-analysis, and sensitivity was highest in chemiluminescence immunoassay and lowest in lateral flow immunoassay. And total antibodies was better than IgG and IgM, and antibodies against the spike protein was generally high detection rate than nucleocapsid protein, and the specificity was generally good. When you use antibody tests, you always remind that there are post-test probability problems. It is the probability of a disease after the diagnostic test result. And in case of positive result, post-test probability is equal to positive predictive value. So, for example, in South Korea, there are about 11,000 confirmed cases, and which correspond to 0.02% prevalence. So, in this situation, and assuming the test sensitivity is 85% and specificity 99%, and when we calculate the positive predictive value, it is only 1.9%, which means that if you have 100 positive results, 98 of the results are true, negative in true, and only 2% are real positive. And if the prevalence was 10 times higher and corresponding 0.2%, the positive predictive value are still 14.6%. So low prevalence and poor performance all lead to low post-test probability value. So, and about antigen tests, there are only a few evaluation reports, and both reports show that poor sensitivity of antigen tests. Particularly in a report that compared the 4 antigen test kits using same samples, there are even 0% sensitivity and 16% sensitivity. So you cannot use antigen tests rather than molecular tests. It can be only justified in resource-poor settings. So in summary, molecular testing is the main diagnostic tool for COVID-19 testing, and other assays such as antibody tests only can do limited role at present. And COVID-19 testing needs professionalism and cooperation among laboratories and government and IVD company and communication. So I hope and we hope and believe that all clinical laboratories in the world will contribute to overcome COVID-19 pandemic. Thank you very much.
Thank you, Dr. Kehoe, for a very comprehensive overview of testing for the SARS-CoV-2 virus in Korea and your expert opinion on the relevance of tests currently available. We have received a large number of questions from our participants, and we will make these available to you so you can answer them at leisure. We understand the constraints of time, and we are really very, very grateful for the time that you have given us. Now, in the best interest of moving forward with our agenda, we will move on to our second speaker of the day, Professor Kevin Rooney. Professor Kevin Rooney is a consultant in anesthesia and intensive care medicine at the Royal Alexandra Hospital and is also Honorary Clinical Associate Professor at the University of Glasgow in Scotland in the UK. Passionate about critical care, he became Scotland's first Professor of Care Improvement. He developed a campaign to improve outcomes, achieving significant risk reduction in mortality from sepsis and cardiac arrest. He has shared his expertise with other countries, including Brazil and Qatar, and has been advisor to the WHO on H1N1 in 2009 and 2010. An award winner, Professor Rooney makes a difference to the care of critical care patients on a day-to-day basis in Scotland. We are privileged to be hearing from him now.
Hello and welcome from Glasgow. My name is Kevin Rooney and I would like to thank Dr. Sumida and BD for inviting me to share my experience of managing COVID-19 in ICUs in Scotland.
Thank you, Dr. Sumida, for inviting me to talk today and share our experience of COVID-19 in Scotland. As you can see, over the last 5 years, I have provided advisory support and had grant awards from several organisations, but they do not provide any real conflict of interest within this presentation. As Dr. Sumida stated, I am a consultant in anaesthesia and intensive care medicine at the Royal Alexandra Hospital in Paisley in the west of Scotland. My hospital is a 700-bedded hospital and we are part of NHS Greater Glasgow and Clyde. And we provide services to a core population of about 1.2 million people and 50% of tertiary referrals for Scotland. I'm a fellow for the Scottish Patient Safety Programme and I led a national campaign to prove outcomes from sepsis and cardiac arrests for Healthcare Improvement Scotland. I'm also faculty for the Institute for Healthcare Improvement based in Boston, United States. For those of you that are unaware of the geography of the United Kingdom, Scotland is in the northern part of the UK. We have a population of just over 5 million people and we have an integrated health and social care delivery system. The last I heard of it, we spent about £12 billion each year on healthcare, and we have 14 health boards, territorial health boards, and 8 support boards. That would be things like Healthcare Improvement Scotland, NHS Education for Scotland, and organisations like the Ambulance Service. So the purpose of this presentation is to share with you all what we have learned, or certainly I have learned, from the COVID-19 pandemic in Scotland. Well, the first thing that I have personally learned is the importance of flattening the hump, doing this through social distancing, shielding and advising patients to stay at home. By doing this, we prevented a surge for the capacity of the NHS and it allowed us to continue with providing healthcare even at this increased demand. There are unique operational and clinical issues to think about when you're dealing with a pandemic, and the most important thing I have also learned is to prepare, prepare and prepare. Planning and preparation is key to how you will manage the pandemic. And you have to think is what will your surge capacity be? Is it going to be 2 times, 4 times or even 8 times? We looked at increasing the critical care capacity for NHS Scotland up to potentially 4 to 8 times the current original baseline capacity. But when you're thinking about increasing surge capacity for critical care, people think it's just ventilators. However, it is far more than ventilators. There are other equipment out there, such as infusion pumps, NG feeding, lots of different things. It's important to have an adequate supply of PPE and consumables, and that certainly was a challenge at the start. And also the power for your hospital, and what's the maximum number of devices or ventilators that you need to have. So there are unique case definitions for COVID-19 infection both in the community and within the hospital. Up until recent, people with the following signs and symptoms in the community were advised to self-isolate for 7 days, and testing was not required. However, in the last week, as we're moving to move away from lockdown, any person with the following signs or symptoms is required to attend for a test so that we can move to a test and trace strategy. The signs and symptoms and the case definitions of COVID-19 within the community are recent, i.e. within the last 7 days, onset of a new or continuous cough and or a high temperature, and more recently we've added in a loss of or a change in your sense of smell or taste, otherwise known as anosmia. The case definition for those that are admitted to hospital of COVID-19 is either clinical or radiological evidence of pneumonia, or the acute respiratory distress syndrome, or an influenza-like illness, namely a fever greater than or equal to 37.8 degrees centigrade, and at least one of the following respiratory symptoms. Again, persistent cough with or without sputum, hoarseness, nasal discharge or congestion, shortness of breath, sore throat, wheezing or sneezing. It is important that we isolate patients with COVID-19 from other patients within the hospital, as getting COVID-19 when you're already unwell gives you a very high predicted mortality. As such, within each hospital, we have both a red and green clinical pathway. The red clinical pathway is for anyone with the signs or symptoms or who fulfills a case definition of COVID-19 within the community or the hospital. The green pathway is for people who are normally presented to hospital with other illnesses. In essence, if you present to hospital with shortness of breath, hypoxia, or new continuous cough, loss of sense of taste or smell, and fever, you will go down the red pathway. Anyone else goes down the green pathway. However, there are other reasons and other causes of someone being hypoxic other than COVID-19. And sometimes we do see these patients going down the red pathway. As in the case definition, both cough and fever are the two commonest symptoms on presentation to hospital, and this is closely followed by shortness of breath. But what is also important is that a significant proportion of patients, somewhere between 15 and 20%, present to hospital with symptoms of diarrhea and vomiting. And as such, people with an acute abdomen could have COVID-19. Again, this makes the challenge of which pathway, the red COVID pathway or the green non-COVID pathway, difficult to follow. Patients with comorbidities are at increased risk of developing COVID-19 and of having a poor outcome. Chronic cardiac disease is by far the most common comorbid condition, closely followed by diabetes and then chronic pulmonary disease. I will now go on to share with you the demographics of those people who present to hospital with COVID-19. The median time from onset of symptoms to hospital admission is around 4 days, and the average hospital length of stay is 7 days for all patients. These patients who require critical care usually present to the ICU in their second week of illness, so they've been at home for around about 4 days and then in the hospital for 2 or 3 days. The age bracket for the critical care population is mainly in the 50 to 75-year-old group, with the median age being of 60 years. The most common symptoms, again, for those admitted to ICU are cough, fever, and shortness of breath. And again, with similar common comorbidities as for the general population of chronic cardiac disease, mainly hypertension, diabetes, even without any end-stage complications, and chronic pulmonary disease. Men are disproportionately affected here, with 70% of patients who require critical care being male compared to 30% female. People of a black and Asian and minority ethnic groups, again, they are disproportionately affected, with 33% of all critical care patients being of a BAME background. And this is compared to 22% in the general UK population. 75% of those patients who are ventilated are classified as obese, with a BMI of greater than 25. Just under 2% have end-stage renal disease, and by that I mean require dialysis in the community. And this makes them 1.58 times more likely to die. I will now share with you the Scottish COVID-19 test numbers and the results positive for NHS Scotland as of the 1st of June. On the 1st of June, there were 18 new confirmed cases of COVID-19 and 1 new reported death. A total of 115,259 people in Scotland had been tested through NHS labs. And of these, almost 100,000 were confirmed negative, with just under 15,500 being positive. These numbers are an underestimate of the true burden of the disease and the number of cases, because up until recently, not everyone with the virus will display symptoms, and not all of those with symptoms will be tested. Of the 15,000 who were positive, just over 3,500 inpatients have been discharged from hospital since the 5th of March. Last night, or the night before the 1st of June, there were 735 patients still in hospital, 20 of whom were in intensive care. And as of the 1st of June, unfortunately, there had been 2,363 deaths within NHS Scotland related to COVID-19. People often ask, how does Scotland and the rest of the United Kingdom to compare to other European countries with regards to COVID-19? I can now share with you an update of COVID-19 across the EU as of the 31st of May 2020. As you can see, the United Kingdom, so that's England, Scotland, Wales and Northern Ireland, have had the vast majority of cases and deaths related to COVID-19 within the European Union. We have our reported cases of 410 per 100,000 of our population and a reported death rate of 57.3 per 100,000. The incidence is higher in Spain with a higher reported cases and a higher reported death rate. And again, I think the variation in the reported cases and reported death rates across Europe is related to when you moved into lockdown. When dealing with any pandemic of a respiratory nature, it's important to think about operational planning. The first thing to think about is actually oxygen. What are the number of oxygen outlets that can be simultaneously supported by the vacuum-insulated evaporator of oxygen within your hospital, and what its location? As each ward that is further away from the VIE, the flow rate of oxygen will be less. You need to take into account the flow rates of the ventilators, non-invasive ventilation, and high-flow nasal oxygen to see that do you have enough oxygen to maintain all the ones that you will require. You need to look at about different ways of providing oxygen within your hospital and using portable oxygen concentrators if needed. I think it's important when thinking about your oxygen supply to communicate that the importance of reducing consumption by avoiding hyperoxia and eliminating waste of oxygen supply to your clinical staff. It's important that you have an adequate supply of oxygen cylinders to facilitate transfer of patients between EDs, wards, ICUs and CT scans and emergency use. The number of air outlets is equally important, as is their locations. And one of the ways we managed to save on the oxygen use was by converting our ventilators to run on air rather than just oxygen. Team working and good communication is key to working in any pandemic. It's important that you operate a shared leadership model with regular meetings so you have situational awareness of the impact of COVID-19 on your hospital. So you aren't just focused on your silo, you're aware of how many patients there are in the ED or the specialist assessment and treatment area for COVID-19 and how many patients there are in the wards. Because quite often we know in the ICU that these patients will end up with us. At the start, we had lots of hospital walk-rounds and had a very detailed plan for an escalation and had regular virtual meetings to plan for things. We're asking our staff to work under very extreme conditions, and it's very important that we look after their mental health and well-being. And we have set up within our hospitals rest and recuperation hubs where we can provide refreshments for our staff and also downtime areas and actually psychological support if needed. It's also important to recognise that even within our staff we will have high-risk groups who are immunosuppressed, have comorbidities or are near retirement. And as such, we need to protect our staff as well as our patients. Other things to consider in operational planning in the event of a pandemic is the importance of imaging with the radiology department. We have seen an increased use of point-of-care ultrasound and are using chest ultrasonography far more frequently. With regard to CT scans, we have set up a scanner which is for COVID-19 patients and again another scanner which we use for non-COVID-19 patients. This makes it easier and avoid any downtime with regards to cleaning between patients. An early stage is important. You consider an early reduction in those requiring an elective operation who have a potentially prolonged admission. This will facilitate the deployment of staff, allow them to be trained, and we have limited our operations to urgent and cancer cases. We know that someone who has a laparotomy or a hip replacement with COVID-19 has a far worse outcome, and as such we had an early cessation of these operations during the pandemic. It's important to work with your IT system and with your medical records to look at e-solutions with regards to COVID-19. Within the NHS, we're still a largely paper-based organisation, but we have seen an acceleration in the use of computers and PCs with regards to electronic healthcare records. Developing lab order sets for COVID-19 patients and other diseases has eliminated non-essential tests, and we've also seen an increased use of point-of-care testing. Again, as I said, preparing for surge capacity is more than just ventilators. You need to work with the other departments such as pharmacy, because if you're going to quadruple your critical care capacity, you need to think, how do we provide medication based on this maximum surge capacity? Think about the sedatives you will need, the opioids, the vasopressors to support circulation, the muscle relaxants to facilitate ventilation. And things as simple as NG feeding. Do you have enough feed? Do you have enough pumps? VTE prophylaxis, stress ulcer prophylaxis, and replacements of electrolytes, as well as consumables and machines to provide renal replacement therapy. What has been very difficult for both patients and staff and their relatives is actually we've had to institute restrictive visiting to slow down the pandemic of the disease and social distancing. And as such, since the middle of March, there has been no visiting allowed within our hospitals. This is difficult for our patients, but far more difficult for their relatives, who sometimes say goodbye to their relative at the front door and then may never see them again. As such, we're thinking of new ways of sharing progress with regards to a patient, and we're using FaceTime and things like vCreate to share updates with our patients. As part of your operational planning, again, we don't just think about the ventilators, we need to think about the staff. Because if you're doubling and quadrupling your critical care capacity, you need people to staff the ICUs. So it's important you train these staff. And again, this is another reason why a cessation of elective operating early will allow you to redeploy your staff and train them. You need to identify the availability and the expertise of the doctors and nurses within your own hospital. Think those trained in anaesthesia, medicine and surgical specialties. What ex-critical care nursing staff is there within the hospital, and what doctors or trainee doctors have previously worked in intensive care units. Staff are redeployed on their skills rather than their seniority. I can see more junior trainee doctors taking on more senior roles. Our normal ICU staff, or our baseline ICU staff, have become more supervisory rather than just providing the bedside clinical care. And as such, an ICU nurse may supervise one or two non-ICU nurses who are looking after patients. It's important to think that anyone can help with moving equipment, restocking and administrative tasks, and things like prone positioning, so we can actually redeploy people to help with these things. As a consultant model-led critical care unit, we had moved to providing resident on-call with a consultant living in the ICU 24 hours per day. In fact, we had 2 consultants living in 24 hours a day. Another thing you can do is actually think about mobile emergency rapid sequence induction teams or rapid intubation teams and merit teams. And as such, these teams can go around the hospital, collect people, sedate, intubate them, and then transfer them to the intensive care unit. Moving on from the operational issues, it's important to think about the clinical issues in relation to the pandemic. The first important thing to think about is conserving oxygen due to the limited oxygen supply. And as such, we've moved to targeting oxygen saturation from 92 to 96% for ward patients and 90 to 94% in the ICU. This may sound a bit draconian, but actually we know that hyperoxia or oxygen saturations of greater than 96% can be detrimental to our patients. So we're avoiding hyperoxia, and things like high flow nasal oxygen, which have been relatively routinely used in the past, have been abandoned due to the high flows of oxygen required. Also, high flow nasal oxygen is a potentially aerosol generating procedure. And we've now thought about appropriate use of CPAP or non-invasive ventilation, again because that uses up your oxygen supply very quickly. The location of where you're going to nurse these patients is very important. And as I said earlier, we have both a red and a green pathway. Initially, for patients in the red pathway, we used our negative pressure rooms, but these rooms are limited throughout any hospital, certainly in the United Kingdom, and as such we had to move to providing care for these patients in cohorted areas, especially if an aerosol generating procedure was being performed. Our ICU has moved to having a COVID-19 ICU and a non-COVID-19 ICU. However, because an aerosol generating procedure could be performed in both clinical areas, we had to wear full PPE in both ICUs. We reserved our single rooms for those in high dependency areas for those requiring non-invasive ventilation, or in fact those without COVID-19. Intubation in COVID-19 patients is tricky. These patients already are profoundly hypoxic, have very little reserve, and again, things like bag valve mask ventilation increase the risk of aerosolization of droplet particles. And as such, we changed the way that we intubated the patients. The ventilatory management of these patients is as is routine, with protective lung ventilation and conservative fluid strategy, the use of neuromuscular blockade, and actually we moved away from a very high PEEP to a lower PEEP strategy. And we used prone ventilation very often in both spontaneously breathing patients in the wards and in the critically ill ventilated patient. So how does prone ventilation work, and what is the physiology of prone positioning? Well, we normally perfuse the dependent parts of our lung the best. So if you're lying supine, you perfuse the dorsal parts of the lung. But due to the high transpulmonary pressures and the differentiation between the ventral and the dorsal areas, in the dorsal areas you get collapse, usually due to the pneumonic process. So the transpulmonary pressure is higher in the ventral areas. As a result, that area gets preferentially ventilated and over-distended, which could cause potential damage to the lungs. And again, you're also perfusing the part of the lung that is least well oxygenated. When we turn the patient prone, the blood flow still preferentially goes to the dorsal regions, but the alterations in transpulmonary pressure become less severe, and as a result, you get decreased overdistension of your ventral alveoli and less ventilator-induced lung injury, and you get decreased collapse of your dorsal alveoli and better ventilation and perfusion as a result. So what were the other clinical issues with regards to the pandemic? Well, within the ICU, there's an area where that we routinely perform aerosol generating procedures, and I will talk about that soon. If we perform an aerosol generating procedures, it's important that we wear a full PPE. In the summer, this made dealing with these patients very complicated and very hot and getting staff bothered. Corticosteroids are something that have come and gone within ICU, and people who like steroids always talk about, well, we started it here and the patient get better. But a lot of us in ICU also talk about the SASH effect, that when the patient is 2 to 3 weeks down ICU, people wish to start steroids and said, steroids almost started here, but actually the patients get better. If you give high-dose steroids to someone with COVID-19, you'll provide a worse outcome for your patient, and you'll get prolonged viral shedding. However, there is an evidence base that low-dose steroids may be beneficial in COVID-19 patients or in those requiring septic shock. And as a result, we're taking part in 2 trials, the recovery trial and REMAP-CAP, where we are allocating patients to low-dose steroids if they fulfill the requirements. Cardiac arrest is more difficult in the times of the pandemic as well, because it is a bag valve mask ventilation is an aerosol generating procedure. However, chest compression is not an aerosol generating procedure. So in the community, we're advising only compression, only CPR, and even within the hospital, if someone has a cardiac arrest, we're advising compression only CPR until everyone is in the appropriate full PPE. So one of the challenges of the pandemic has been our critical care bed capacity within the United Kingdom. And the UK has a far lower provision of critical care beds per head of the population than most European countries. This slide shows data from 2012, but we had 6.6 critical care beds per 100,000 capita of the population, compared to Germany, which had about 26. I believe the United States of America's critical care bed capacity is around about the 35 per 100,000 of the population. As a result, we've had to look about who requires admission to intensive care. And admission to hospital, we look at patients and identify them using a clinical frailty scale to assess their degree of reserve. We consider underlying comorbidities and underlying health conditions and the reversibility of the illness. And it's important that with all patients, have they COVID-19 or not, we discuss the risks, benefits and likely outcomes of any different treatment options. However, within the United Kingdom, there has been no critical care triage on admission to or during the ICU stay. I will now share with you some information which has been unique to Scotland and is collected as part by the Scottish Intensive Care Society Audit Group on patients with COVID-19. And this document was published on the 13th of May. During the period from the 1st of March to the 2nd of May, Scotland had 483 admissions related to 472 patients with lab-confirmed COVID-19. Our peak period of patients with COVID-19 admitted was between the 29th of March and the 6th of April. And the groups, as stated earlier, the highest number of admissions included those aged 60 to 69, men, and again those living in socially deprived areas. By the start of May, 159 patients had died from COVID-19 in ICU, and that's 32.9%, with 44% of patients being discharged alive from the ICU, and just under 21% of patients were still in the ICU. These patients can have a long length of stay in the ICU, and we have a few patients still at a month's duration within the ICU. The survival is measured at 30 days after ICU admission was 60%. However, the survival is lower than that in those who required advanced respiratory support and in the oldest age group. For those that came to ICU, around 80% of them required advanced ventilator support, invasive ventilation, 80% required cardiovascular support, i.e. vasopressors, and around a third required renal replacement therapy. Within the UK, the Intensive Care National Audit and Research Centre has provided weekly reports on all the patients admitted to intensive care in England, Wales and Northern Ireland. And they have compared these with patients who normally present with viral pneumonia from historical data between 2017 and 2019. As you can see from this slide, that the mortality in IGNARC data for patients with COVID-19 has been around about 43% compared to 21% for COVID-19. The average length of stay for survivors is 11 days and 9 days for non-survivors. Again, like Scotland, over 70% of those patients require advanced respiratory support, and a significant proportion also require cardiovascular support, with just under a third requiring renal support as well. In the IGNARC data, if you look at outcome by invasive ventilation, i.e. those who were ventilated invasively and those who were not, as you can see here, if you received a non-invasive or just oxygen support, you had a 70% chance of survival. However, the minute you were ventilated, within the first 24 hours, your mortality went down to 50%. Other issues which we've noted in the pandemic has been of central dialysis and arterial lines all being more likely to clot. And as a result, with things like renal replacement therapy, we have moved to having timed treatments rather than continuous treatments. We are using citrate more often, pre-dilution, and we've increased the blood pump speeds. And also we are going back to using heparin, and again titrating it using anti-10A levels. These patients are hypercoagulable and have a higher incidence of VTE. And again, our VTE prophylaxis doses have increased as a result. And again, we routinely measure the anti-10A level when we give them their low molecular weight heparin. The cause of this hypercoagulability may be that these patients are dehydrated. They've already had high insensible losses due to their pyrexia. They may have been aggressively diarrheous. And as a result, it's important we titrate the fluid balance as per the individual patient requirement. We've also noticed an element of insulin resistance of these patients, and they're requiring very large doses of Actrapid due to their stress hyperglycemia. The hyperglycemia may also be related to some of these patients being in low-dose steroids as part of the randomized controlled trials. As a clinician, it's important we think about the clinical perspective of infection control, as within the ICU, we often see aerosol-generating procedures. And aerosol is produced when an air current moves across the surface of a film of liquid. And aerosol-generating procedures are any medical or patient care procedure that results in the production of airborne particles. The greater the force of the air that we use, the smaller the particles that are produced. So that things like bag valve mask ventilation can produce very small particles. These airborne particles can be less than 5 microns in size and can remain suspended in the air, travelling over a distance, and may cause infection if inhaled. This is different to normal COVID-19 transmission, which is spread by droplet spread. So there is a potential for airborne transmission of the virus, even though it's normally just spread by the droplet route. As such, we have to wear full PPE in critical care settings. Here we have a list of the current aerosol generating procedures as identified by Public Health England and Health Protection Scotland. And they include intubation, extubation, and related procedures such as manual ventilation and open suctioning, tracheostomy, bronchoscopy, any surgery or post-mortem procedures involving drills, some dental procedures, and non-invasive ventilation such as BiPAP and CPAP, high-frequency oscillation, sputum induction, and high-flow nasal oxygen. As you can see, this is a huge list of potential aerosol-generating procedures and the potential risk for staff. As such, we have recommended personal protective equipment for all healthcare workers in secondary care, primary care, and in care homes. Within the ICU, if a patient is getting a single, or anywhere where a patient is getting a single aerosol-generating procedure, the person should wear single-use disposable gloves, a disposable fluid-resistant gown, an FFP3 mask, and face and eye protection. Within the ICU, because this is a high-risk clinical area, the full PPE is equally applicable. In areas where we are cohorting patients where there's no risk of an aerosol-generating procedure, equipment would be disposable gloves, disposable plastic apron, and a disposable fluid-resistant surgical mask. The masks can be used for sessional use. However, it's important that we would change the gloves and the aprons between patients. Again, within the ICU setting, the FFP3 mask should be used for sessional use, unless the person is performing an aerosol generating procedure, and it should be changed immediately after that. So what is our experience of point of care testing within the ICUs? So within my ICU, we currently use 2 point of care devices. We use the glucometer, the Abbott Freestyle Precision Pro, and the blood gas analyzer GEM 5000. There is a concern that actually doing point of care testing within the ICU and actually putting blood within a blood gas analyzer or again on a BM machine is a potentially aerosol generating procedure. And as such, it's important that the staff always wear full PPE. We use the glucometer instead of the blood gas analyzer to measure blood glucose because we feel that the quality control is better, and I've always been advised to do that by our labs. The routine measurements we take in our blood gas analyzer are blood gases. We use lactate to help guide resuscitation and prepare the surviving sepsis recommendations. As I said earlier on, that we use regional anticoagulation with citrate on our renal replacement therapy. And as a result, it's important that we measure a venous ionized calcium on a regular basis. If there's a history of smoke inhalation, we would measure things like carboxyhemoglobin. And every now and again, we measure central venous oxygen saturations to help us with measuring oxygen delivery. People commonly ask, what is the incidence of sepsis with patients with COVID-19, especially in the ICU population? So to answer this question, I think it's important that we think, what is the definition of sepsis? Well, the Sepsis 3 definition states that sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. And we measure this life-threatening organ dysfunction through the use of the SOFA score, the Sequential Organ Failure Assessment score. As you can see from the right-hand side of the slide, actually any patient who's requiring respiratory support will have a SOFA score of 3 or 4. And to have organ dysfunction, you need a change in your SOFA score of 2. So if you're ventilated, you have a coagulopathy is identified by your platelets less than 100, you have an elevated bilirubin, you're on vasopressors, have an altered conscious level below 12, or have an elevated creatinine above 171, you have organ dysfunction as identified by SOFA. And the commonest reason for sepsis in ICU at the moment is COVID-19, because even just to get into ICU, you're fulfilling the sepsis requirements. Bacterial co-infection is not as common as we thought, and the vast majority of patients who come into hospital, if they have a positive COVID-19 screen, it's safe to stop antibiotics. Bacterial co-infection has been proven to be rare and unusual in all patients, except those who are ventilated in the ICU. I hope you've enjoyed my presentation, and I'd like to thank you all for the opportunity to share our learning in NHS Scotland with COVID-19.
Thank you, Professor Kevin, for giving us such a thorough understanding of critical care considerations in COVID-19 patients. I can see that we are receiving a large number of questions, and may we ask you please to take on a few of them. We understand we'll have time limitations, but let me just try and ask you the most important ones that I can see. Professor Kevin, what is your policy on discharging from hospital and the approach to infection control precautions?
Thank you for your questions, Dr. Sumida. Well, fortunately, I have prepared a couple of slides of our step down of infection control and our discharge from hospital. So I'll move on to these slides. So here we have our guidance on the step down of infection control precautions within the hospital. Step down of the precautions can be considered at 14 days after an initial positive PCR test or symptom onset. If there has been clinical improvement and no fever for 24 hours and the patient is not immunosuppressed, we can then step down precautions. If, however, the patient is immunosuppressed, we would then move on to test them for a PCR. If the PCR is positive, we would then repeat the test again after 7 days. If it is negative, we could step down our infection prevention and control precautions. If the patient, even after the 2 weeks, has no signs of clinical improvement or is continually pyrexial, we would continue with our precautions. So what is our guidance for the step down of infection control precautions and discharging home of COVID-19 patients? And this is to residential settings. So if the patient has been admitted to ICU or HDU during their admission, if they're severely immunosuppressed or having to go home to be shielded, we ask that patient to self-isolate for 14 days from discharge. If they haven't any of these patient factors, we would only ask them to self-isolate for 7 days from discharge. If the patient is going back to a nursing home, we would require 2 negative PCR tests. However, we would still be advocating these patients self-isolate and be isolated within the care home.
Professor Kevin, you've mentioned about the infection control precautions. So I've received a question here about what percentage of staff in your hospital got infected while caring for patients? Were critical care staff more affected?
So certainly critical care staff weren't more affected as far as we're aware, because actually we wear the full PPE, so we're actually shielded from the virus more so than other people are within the hospital and also within the community. But within NHS Scotland, just under 3% of the National Health Service's workforce have been reported absent from their work at one time related to COVID-19. Unfortunately, since the pandemic has started, we've had 7 deaths of healthcare workers and 11 deaths of social care workers. Our social care workforce seems to be higher affected than the NHS staff, with around about 6.5% of the social care workforce being reported as absent from COVID-19 at certain points.
So there's a question on why are certain groups at increased risk of requiring critical care and adverse outcomes?
Okay, thank you for that, Dr. Sumida. I have a slide which should help explain the answer to that. So if you let me share that with you. So as stated in my presentation, that there were certain populations who were at increased risk of developing COVID-19 and having poor outcome. The first one to say is that the male group were more commonly affected than females, with 70% compared to 30% in the critical care population. Rather than a genetic predisposition, we believe that this increased incidence in this population is due to their comorbidities and perhaps the male sex making poorer lifestyle choices, and as a result having an increased incidence of obesity and cardiovascular disease. As you can see from the slide in front of you, that actually poverty has a huge incidence on the incidence of COVID-19, with those patients coming from the most deprived areas having a far greater incidence compared to those from the least deprived areas. I also mentioned that people of a BAME origin had an increased incidence of COVID-19. This is thought to be due to multifactorial. In the UK and certain areas, Obviously, that poverty and deprivation will have an incidence of an effect on this. However, it is also believed that there may be a genetic predisposition in this population with regards to COVID-19, and that is getting currently further investigated.
Professor Kevin, what percentage of patients develop sepsis, and how could one distinguish between viral and bacterial sepsis in these patients?
Well, as I said earlier, that all patients admitted to ICU with COVID-19 fulfill the definition of sepsis, and they have life-threatening organ dysfunction. So the vast majority of sepsis in the ICU is caused by the virus itself. Bacterial co-infection is rare, except in those patients that require invasive ventilation. And as such, any patient who's admitted to ICU and invasively ventilated would receive a 5 to 7 day course of antibiotics for a community-acquired pneumonia. However, it would be stopped after that. We wouldn't use CRP, but we would continue to monitor vital signs, their temperature, and also procalcitonin as a guide as to when and if to start antibiotics. If the patient had an ongoing pyrexia despite a course of antibiotics and an elevated procalcitonin, we would perform sputum cultures, urine cultures, and blood cultures. And if the pyrexia is ongoing and not thought to be related to the virus, we may consider CT scanning the patient as well, looking for a source of infection such as an empyema or other things.
Professor Kevin, what are your sampling recommendations specifically for SARS-CoV-2 detection and diagnosis?
Okay, thank you, Dr. Sumida. To ensure I get this correct, I've also got a slide just to remind me. So, here we have our guidance for sampling. In patients in the community or in a general ward setting, we normally look for upper respiratory tract samples. And this would be a viral nose swab and a viral throat swab in one collection tube, or a single swab, which is used to swab the throat first and then the nose in one collection tube, or a nasopharyngeal aspirate in a universal transport pod. In patients in the ICU and those who are invasively ventilated, we prefer a lower respiratory tract sample, as that has a greater yield of providing a positive result. So if obtainable, we would get a sputum and a lower respiratory tract sample.
Thank you very much for those really insightful answers, and I believe that these have been really valuable to all our participants. And on behalf of everyone who is here today, listening in to you and understanding critical care in COVID-19 patients from the point of view of your experience in Scotland, we are deeply grateful to you. Thank you very much, Professor Rooney.
Thank you, Dr. Sumida. I am happy to help, and I hope everyone found this to be very helpful.
Thank you very much.
On behalf of BD, I wish to thank both our speakers for their excellent presentations of today and for sharing their knowledge and experience. We hope that you, our participants, found the webinar informative. Thank you very much for being with us, and goodbye.